My name is Melora Simon, and I'm an Associate Director on the Advancing People-Centered Care team at the California Healthcare Foundation. For those of you that don't know us, the California Healthcare Foundation, or CHCF, is an independent nonprofit philanthropy that works to improve the healthcare system so that all Californians have the care they need. We focus especially on making sure that the health system works for Californians with low incomes and for communities who've traditionally faced the greatest barriers to care. We partner with leaders across the healthcare safety net to ensure they have the data and resources to make care just and to drive improvements in the complex system that we have in California. I'm really excited today to present the first installment of our work on listening to Californians with complex needs, which focuses on the Bay Area today. As we're leaning into ensuring that CalAIM's reforms are implemented in a person-centered way, it felt really important to listen to the people it intends to help. We've heard a lot about how to implement ECM, enhanced care management, and community supports, two critical CalAIM reforms, from the Department of Healthcare Services, from CMS, and from the managed care plans that hold contracts with providers. But in this work, we wanted to really center the voices of people with complex needs. We turned to our partner, EVITARUS, to lead this work. EVITARUS is a Black-owned public opinion research firm in Los Angeles who led our work on listening to Black Californians. They have deep expertise, not only in the health sector, but also in housing and community safety. And I'm so grateful for their commitment to excellence and equity that they bring to everything they do, but especially to this work. Before I turn it over to Shakari Byerly, the managing partner of EVITARUS, I also want to thank the two Bay Area community partners who recruited participants and created the safe, trust-based environments for them to share their stories and experiences. To the teams at St. Mary's Center and West Oakland Health Council, we couldn't have done this without you. So without further ado, let me turn it over to Shakari to share the approach and, most importantly, what they learned along the way.
Thank you so much, Melora. And it's truly a pleasure and honor to be with you today to present the results of the Listening to Californians with Complex Needs project, particularly the findings that emerge from our Bay Area work. Just an overview of our presentation today. I'll talk a bit about the research objectives, the methodology we use, and also some of the participant characteristics. We'll then move through to actionable themes that emerge across populations. And we're hoping that this will provide you with some insight into what those facing complex health, mental health, and social situations desire from both healthcare as well as social supports. We'll then talk about specifically some of the population-based themes that emerge. So for those experiencing homelessness, those who have a history of substance use disorder, other behavioral health challenges, what are some specific themes that relate to their needs and what they're looking for in the service providers that work with them? On the next slide, you'll see an overview of our research objectives, which were, one, to gain insight into the experiences of Californians with complex needs. And by complex needs, we mean those residents who are experiencing homelessness or housing insecurity, recently housed or have unstable housing, those who are coping with behavioral health challenges and or substance use disorder, those who are aging and that have functional impairments and may have challenges living independently, as well as those who may face each of these previously mentioned conditions, but are also impacted by recent incarceration. Number two, we wanted to identify the types of resources, services, and health supports that they would find most helpful to promote their health, their well-being, and their quality of life. So we conducted the research from early October through early December. It consisted of 34 one-on-one interviews with those with complex needs. And many of our participants experienced two or more of the needs that I mentioned in the aforementioned in the previous slide. This was supplemented with 3 focus groups with caregivers who support individuals that have complex needs in Oakland. And we wanted to add this additional layer to the research because often those with acute needs or those who are currently in crisis may not be able to speak effectively for themselves. And so we wanted to understand the perspectives of caregivers who may provide a secondhand view of some of the needs and challenges and also what's working well and may not have been working well, and then also get their perspectives on how to deliver, how they deliver quality care and support those with a complexity of needs. Each of the one-on-one interviews were conducted by a professional, trained, qualitative researcher in partnership, as Melora mentioned, with St. Mary's Center and the West Oakland Health Council. The interviews were actually held at one of those respective sites. Participants, again, were those who were currently unhoused or recently housed, those with behavioral health concerns and particularly mental health conditions, including dementia, bipolar disorder, schizophrenia, depression, PTSD. And there were participants who had a range of other challenges and experiences, particularly with chronic health conditions such as hypertension, diabetes, substance use disorder, and as I mentioned previously, a number of participants also had prior experience with incarceration. On the next slide, you'll see an overview of the demographic characteristics of those who participated in the one-on-one interviews. Slightly more male. We had 19 men and 15 women, and the age range of participants was age 40 up to 73. In terms of the ethno-racial background, 74% of our participants identified as Black or African American. And as many of you may know, in Oakland in particular, roughly it's estimated, the county estimates that around 70% of those who are unhoused are African American or Black. We had a range of other ethno-racial backgrounds represented, including 9% who identified as mixed or biracial, 3% who identified as Latino, Latina, or Latinx, 3% who were Asian American or Pacific Islander, 6% who identified as white, and 3% who came from a range of other backgrounds not previously mentioned. On the next slide, you'll see a breakdown of the complexity of needs that were represented in the sample of people we spoke with. And again, these categories aren't mutually exclusive. There's quite a bit of overlap here. But we had roughly about 3 in 5, or 59%, who were currently unhoused, followed by a quarter who previously were unhoused and were either in temporary housing or had just been placed in supportive housing. Only 15% had never experienced homelessness. In terms of behavioral health issues, starting with substance use, we had 44% of respondents who had some form of prior substance use or current substance use. 41% actually had active substance use, and 15% had no history of substance use disorder. On the next slide, you'll see the percentage of older adults who shared that they had multiple conditions, chronic conditions, and that includes nearly 4 in 5, or 79%, who indicated such, and just 1 in 5, or 21%, who did not state that they had a complexity of health conditions. In terms of mental health conditions, 47%, or nearly 53% indicated that they did not suffer from mental health conditions. 47%, nearly half, said that they did. And 29% of our population that we spoke with had prior experience with incarceration. So what did we learn? There are 4 major actionable themes that I'd like to review today in participants' own words. One of the domains is that participants really emphasize the value that they would derive from providers, both healthcare providers, mental health care providers, other behavioral health service providers, and social service providers who asked them about their goals and really sought to understand their perspective on what they wanted in terms of good health and also good quality of life. They also expressed some frustration with the fact that providers didn't seem to recognize what might be out of reach for them in terms of adhering to protocols or working toward their own stability, either with housing or as they in their journey toward recovery from substance use disorder. Participants also indicated how valuable it would be to have whole person-centered care that would allow them to go through one door and do one-stop shopping. So to the extent that there were resources on site with healthcare providers or with social service providers that could cross purposes. So if they were seeking social services, and for example, if they were a member of a senior center, also having that senior center connect them with resources for health or some type of care navigation for housing or other needs that they might have. Finally, participants emphasized the importance of offering services and care with empathy. They wanted to know that people cared about them and that they weren't just a number on a roster. Many appreciated the fact that our systems are often overburdened, particularly given the crisis in homelessness, and also with housing itself and supportive housing as an additional layer, but the importance of respecting the dignity and personhood of those who are facing complexity of challenges. On the next few slides, you'll see some quotes that allow you to hear directly from participants. In the domain of seeking to understand goals, very few participants indicated that their providers or their case managers or care partners actually asked them what their goals were for better health. Participants nonetheless underscored that they have agency, that they have a desire for self-determination. They were looking for people to help them help themselves. In the words of one Black man from Oakland, age 67, no, they, the healthcare providers, don't ask about your goals. They get you in and out like fast food service. Nobody's sitting and talking to you. Half the time, they haven't even read your chart. Filipina woman, age 65 years old, from Oakland, said they, the healthcare providers, don't inform you of the alternatives, you know what I mean? Or they already have preconceived ideas about treatment options, like my ears. I said, I'm having a weird sensation in my ears or something. Can I get a hearing test? Oh, we'll give you a prescription for drops. Well, that's not what I wanted. See what I mean? They already have their way. On the next slide, you'll see the words of additional participants. One white man in Oakland, age 68, talked about how often services are contingent upon resources that they don't have. For instance, this participant in particular talked about the challenges with prioritizing housing because they're so focused on the day-to-day needs for warmth, for food, for a shower, that it's difficult to plan ahead to map out the steps that might get them to a housing placement. Others also talked about the difficulty of prioritizing health without housing. Still others indicated the need for computer literacy, as many services require access to a computer, for example, to make appointments or to apply for affordable housing. They also underscored the importance of stable, timely, and accessible transportation. And I'll read the quote here from our participant in Oakland, age 68. You're sort of on your own, and when you're out on your own and you're homeless, you look for warmth, food, a shower, your primary needs. That's what you're focused on. You're constantly trying to meet those simple primary needs, and then you're neglecting the long-term needs like housing because your primary needs take a priority. On the next slide, you'll see another dimension of this theme of understanding the perspectives of those with complex needs that are navigating a number of different resources or the need for resources that are often out of reach. Namely, wanting to eat healthy meals but not having a place to prepare them. Being unable to consume healthy food without dental care, or seeing a gap between what their SNAP benefits are and the cost of food and what's available in food pantries. Participants also talked about facing financial and legal barriers, such as needing legal help or navigation support to access earned retirement income. In the words of one Black woman from Oakland, age 68, "I've gotten the dentures before and they hurt my mouth. I can't eat with them. I need to eat, and I can't eat healthy foods that I need to eat because I don't have my teeth." That's a health problem. It's been hard because we're at a standstill. You try to move forward, but then there's roadblocks, that hit you. It seems like there's no way around. On the next slide, you'll see an example of our third theme, which is make it one-stop shopping, one place where people can get a variety of their needs met or pointed to resources that might be able to help them. Specifically, they described challenges and also strategies for navigating housing and social service systems. Many talked about maintaining a P.O. box so that they might have an address where they could receive important notices and mail, paying for a smartphone to stay connected, and also networking with others who were in their social network, or if they were unhoused, who were also journeying toward permanent housing, communicating by word of mouth to see what's available. They expressed confusion about which providers to turn to for various needs. Many said that if they had one place where they could go to get a range of resources, then they wouldn't have to rely on things by chance, that it would make it much easier than having, especially given the difficulties of transportation, of having to go place to place or office to office to get their needs met. Other than AA, participants describe substance use treatment as particularly hard to identify. In the words of one Black man, age 70 years old, "Well, a friend of mine told me about this place about a year ago. He used to work as a security over here on the gate. He told me about it. I decided to come in and check it out myself because I need somewhere to stay, That's how I got hooked up." So this idea of, we had some participants who talked about walking down the streets to try to identify churches or nonprofit organizations that might be able to assist with housing, with food, with other basic needs, and that there was no single resource either online or in the shelters or other network places that they were able to find that really would enable them to navigate services and resources effectively. The next slide. Our fourth theme, in terms of our actionable themes across all of the interviews, were the importance of offering care and also services with actual care and empathy. In the words of participants, they often encounter case managers or those who are working to provide resources that are overburdened with the number of requests. And when they do engage, the care and the empathy is often missing. Participants valued individualized care, something as simple as a smile or remembering their name, including them in social activities, delivering on promises, and being honest about what case managers, service workers, healthcare providers could or could not do. They also talked about the importance of, or the challenge of having turnover as it relates to case managers and other personnel that they were in contact with. In the words of one Black woman, age 62, she says, "I've had 3 case managers, representatives. This is my 4th one. They shift me around like that, and I don't like it." This woman also talked about how each time she had to recount her story, she had to share her history, which was an extra burden that made it particularly difficult. Participants also highlighted a number of areas of dissatisfaction. I mentioned before a lack of familiarity on the part of caseworkers. Others described discrimination, sometimes due to the fact that they were on Medi-Cal and did not have private insurance. Others expressed that they experienced disrespect, and they preferred healthcare providers that shared their racial or ethnic background. Others described long wait times and a lack of follow-through. For example, unreturned phone calls or canceled appointments without much notice. And there was a keen awareness of the financial benefits for service providers enrolling them in their programs, which they found dehumanizing. In the words of one participant, described how he was very aware that there was somewhat of a homelessness industrial complex, in his words. The fact that many of the services aren't focused so much on outcome of getting someone housed to the extent that they can, but he felt that he was just a number on a caseload, and the more people that were serviced in general, as opposed to the people that were actually received a housing placement, he said there was a disconnect, and he could tell the lack of empathy in that approach. In the theme of offering care and empathy in service delivery, many noted gaps in their post-discharge as they were transitioning from one setting to another, and this is particularly emerging from the focus group findings. Challenges with getting aftercare from a hospital discharge, or a focus just on urgent care rather than services and resources that were meant to sustain and provide long-term stability and wellness. In the words of one female caregiver in Oakland, they just want to hurry up and rush us out and get to the next person. It sucks. Now, instead of going to the place, he's home. Now he's supposed to go to like an outpatient and do all that. And the doctor was supposed to set him up to a facility. They told him to call insurance to do it. We called the insurance, and the insurance was like, your doctor was supposed to set it up. Now he's in limbo. When we left the hospital and stuff, they didn't tell you how difficult it's going to be. I feel like they should give you a little bit more tools that can help us a little bit at home as opposed to being at the hospital. And the next slide. We'll go through some of the population-specific themes, and we had three primary populations: those who were unhoused, those who faced behavioral health or mental health challenges, as well as those who had functional impairments and had challenges living independently. In addition, we also interviewed those who had prior instances of incarceration co-occurring with the other situational health or behavioral needs. Participants talked about five primary areas: housing that was unsafe, compromised their safety or their wellness or their recovery, the stigma associated with health and therapy that persists in the community, and also the lack of trust, which also emerging from that was the importance of having integrated peer support services as a bridge to counseling or other more formal forms of mental health. Some also talked about the burden of having a history of incarceration and how that stigmatizes them in the eyes of social service workers as well as healthcare providers. Our fourth theme, caregivers were striving to help meet basic needs and their primary needs, and being burdened with the mental health toll and also the lack of support, as you saw in the last quote, as the person they were caring for needed to transition between settings and not having much information to go on to really provide the care and the resource that the person they are caring for may need. Finally, particularly our senior population talked about the importance of resources that might help them build positive social connections, a sense of belonging with others who are moving toward more stability and a positive path. In the interest of time, I'm going to go more quickly, and I won't have an opportunity to read all of the quotes, but I believe we will provide them to you after the presentation. I'll just highlight some of the specific findings in each of these themes. The unsafety of housing. People spoke about experiences with violence, with assault, with theft, after being put in placements that were unsafe. And many were thankful to have a placement, but talked about, particularly women, the importance of having safe spaces. Some did talk about assault, but then also men spoke about the importance of safe spaces, particularly to protect their belongings. And also those in recovery and who had mental health challenges talked about the difficulties when placements are not specific to their individual needs. Next slide. The stigma I mentioned around mental health and therapy, particularly within the Black community, and the lack of culturally appropriate care was also an important thing. One suggestion or recommendation was that peer support services could help build trust and also bridge that gap. Next slide. The history of incarceration I mentioned earlier often led to participants feeling that they were stereotyped and therefore labeled and cut off from services or dismissed because of that history of incarceration. Those who had experiences with incarceration also talked about the importance of having resources immediately upon reentry into the community, the need for housing support, clothing, a place to shower, mental health care services, substance use disorder treatment, and also the importance of linking them to employment opportunities so that they might build towards self-sufficiency. The next slide. Rebuilding of social connections was important to many, particularly those who had behavioral health challenges like substance use disorder, needing to find a peer network of others who were facing some of the same challenges, but working toward recovery. This was also important for seniors who felt that they wanted to have social connections with people who were their own age, likewise that had complexity of needs, but were working toward better health and stability. Our next slide. Caregivers were striving to meet basic needs for the people that they cared for, but faced considerable challenges, both with technology, with providing care that was more complex than the issues where they had received training, or which were challenges because of the physicality of what might be required if the person they were caring for lacked mobility, but didn't have the medical devices that might help them to move around both in their own home more effectively, but also as they needed to go to and from appointments. Many caregivers indicated that although it was not within their job description, they were taking the people that they cared for to transporting them to and from doctor's appointments or to help meet their basic needs like grocery shopping. As we go to the next slide, I think we're nearing the end here. And thank you all so much for your time and your attention.
Thanks so much, Shikari. We don't have any questions in the chat, and I realize that we are at the end of our allotted time. So if I could ask for Wes's help, I think we wanted to close by just giving people a chance kind of on their own to reflect. Wes just put a link in the chat, and if you can go to that link, it's going to prompt you with this question. Based on what you just learned or just heard today, what is the one change that you feel is most important to better support people with complex needs in the Bay Area? So if you can go there, fill that out, we'll then post up the findings. We feel like this is a really important way to get some feedback on how to turn these stories and insights into information for implementers. So we'll give folks a minute or two to do that, and then can close it out. Thanks so much, Wes, and thanks, Shikari, and everybody for joining. It was really helpful to kind of see these insights and hear them. And we're really looking forward to sharing more insights as we go to additional regions and kind of hear from different populations and be able to kind of synthesize this as a whole. But we think centering and amplifying the voices of the people that CalAIM is trying to help is really, really critical to getting to people-centered care. And we're so appreciative of your time and attention. Thank you.